Well, hello. I am Nurse Fonda from Nurse Fonda LLC.
And I am Ebony, a.k.a. the Unicorn Nurse. And we have...
Hi, Dr. Sabine Lovell. Nice to be here today.
Thank you for coming and joining us.
Yeah, no problem.
We're so excited.
Yeah, I know, right? So tell us a little bit about yourself.
So I'm originally from Texas. I grew up in El Paso. But my mom is European. She grew up in former Czechoslovakia. My dad's American. Mm-hmm. So, so I spent a lot of summers over in Europe. I speak Slovak. But grew up on the border of Mexico. So kind of like a very interesting background. Okay. So, and then my husband's Indian. So we got lots of cultures in our house. Lots of different cultures. I did most of my training in Texas. So I went to like UT Austin for undergrad, UT Houston for medical school, and then did my training out for general surgery at Emory here in Atlanta.
All right.
Did a plastic surgery fellowship in Northeast Ohio, and then realized I needed a little bit more diversity and better weather. So we moved back south.
Okay. Oh, yeah. Awesome. So how long have you been doing plastic surgery?
So I've been in private practice for 3 years now.
Okay. Awesome. So one question we always ask, what's your favorite thing to do?
Oh, yeah. Oh, there's so many good things. It's usually like what my next surgery is. I just love everything about plastic surgery. Tummy tucks are just so transformative though. So I love a good tummy tuck. Like, it's just so rewarding because you see the results like immediately on table. And then what's cool about it is that months down the line, when the swelling starts going down, like the patient's shape like comes in even more, and then they're like even more snatched than what they were on table. So it's just like so cool to see the transformation.
So what makes a good tummy tuck?
Yeah. For you? So I think it's a lot with like, it's so interesting you asked that because with my breast surgeries, I do a lot of like measurements to make sure like the nipples are going to be in good alignment after I do like a lift or, a lot of measurements between the nipple and the inframammary fold, the sternal notch to the nipple. So lots of measurements. For tummy tucks, I feel like it's really important for the surgeon to have like a really good artistic eye. Like for my tummy tucks, like I'm just drawing like, like Van Gogh or something. Like I'm just like, there's nothing, no measurements. It's fun, especially when I'm doing my mommy makeovers. Cause like I'll be, doing my measurements for my breasts with my rulers and everything. And then calipers. And then I move to the belly and then it's all freehand. So it's like fun cause it's like a good mix.
Yeah.
So I think what makes a good tummy tuck is just like a surgeon with a good training background. Obviously you want to go to a board certified plastic surgeon, but also like that has a good artistic eye. And so you want to look at surgeons like before and afters on their website or on their social media page and see like what appeals to you, like because there's some different like looks that some surgeons have in terms of like some just make them really flat. But I feel like it's really important to have like 3-dimensionality. So like to bring in the waist, to have like, the belly button nice and like hooded and like kind of inverted and kind of shadowed. So I think like having a good 3-dimensional landscape for the belly is like really important.
I'm glad you said that.
Right. Yeah. And I have to say, out of the girls that I've taken care of that you have worked on, your belly buttons are just beautiful.
Oh, thank you.
They are phenomenal.
Thank you so much.
I was like, oh my God. I was like, your belly button looks incredible.
Thank you.
So you do a phenomenal job. And I think that's one thing that a lot of people look at too, the belly buttons. No one wants that. I call it a slot machine.
Yeah. Or the really flat one where it's just, there's no nothing. No nothing, just flat.
Yeah. So you do a phenomenal job with your belly buttons.
It's like a lot of attention goes towards the belly button. And so I think like at the end of the surgery, a lot of plastic surgeons might be kind of like, tired or kind of just want to like get through it. But at Muse Plastic Surgery, my partners, Dr. Wright Jones, Dr. Frank Yuan, we spend a lot of time at the end on the belly button because we know how much it matters. And especially like our goal is to get our patients in bikinis and out on the beach and having fun and showing off their new bodies. And one of the telltale signs of plastic surgery of a tummy tuck is the belly button. So if you look really close at people on the beach, you can see some bad belly buttons and scars. Yeah. So we think it's really important.
And that slot machine is always a dead giveaway.
I know, it really is.
That slot machine.
Like you need to stick your quarter right through it.
Get them every time.
Every time.
Yeah, it's crazy. And like you want it to be also the belly button to be a certain position, like on the on the abdomen. You want to make sure it's centered. And a lot of patients will have their belly button just off of center a little bit. So you have to like account for it. So when I'm like marking my belly button at the end, I'm like literally just standing there, like looking from different angles. Like I've already marked it, like where I want to bring the belly button through. I'm like literally there for like 30 seconds or a minute. And I'm just like literally just like looking from like all the angles and make sure that it's like centered, that I like the distance it is from the mons pubis or the pubic area, from the xiphoid. So I'm just like triple checking that everything is good before I make that cut.
Well, you've done a phenomenal job on the girls that I care for.
Thank you so much. I appreciate that.
Yeah. So what about BMI? Do you have like BMI requirements?
Yes. So our BMI requirement is 31.
Okay.
And I preferably like patients' BMI to be below 30. And that's because the literature in plastic surgery, like the articles have shown that a BMI over 30, you have increased complication risk profile.
Okay.
So that's why.
And one thing I want to call out is that you do combinations. So the tummy tuck with the BBLs.
Yeah.
And you do a phenomenal job. So talk about that some. How do you go about choosing which candidates are good for the combination procedures?
Yeah. No, that's a great question. So with all plastic surgery procedures, this is an open heart surgery. This isn't trauma surgery. I actually initially wanted to be a trauma surgeon, and then I just kind of veered off into plastic surgery after I had a rotation in it at the end of my first year of general surgery. But this is elective plastic surgery. Like, we don't want you to die. We don't want you to have a horrible complication. Like, this is elective plastic surgery. So I want to make sure that my procedures are less than 6.5 hours, decrease the risk for blood clots, decrease the risk for anesthesia complications. So when I'm doing my combination procedures, I'm not going to be doing, a brachioplasty, a breast lift, a tummy tuck, and a thigh lift. Like, no, I'm going to talk to my patient about like staging surgeries, what bothers them the most. Then we'll attack that first. And then I usually also recommend to patients like what I think after I evaluate, and do a physical exam, what I think will give them the best like bang for their buck. Like if I were you or if you were my sister, then this is what I would recommend because this is going to give you like the best contour if you're just going to have one surgery or two surgeries. And so when I'm combining surgeries, I just want to make sure that I'm less than 6.5 hours. So usually that'll be a mommy makeover with the breast and the belly or belly and booty. So that's what I recommend to my patients. Or what I do a lot of are lower body lifts after massive weight loss with BBLs. So I would say that's like one of my niche like areas.
Really?
Because a lower body lift by itself will kind of flatten the booty because you're removing a lot of like skin in the upper buttock area. And so it kind of like the shelf that some patients develop after their massive weight loss, you're removing that shelf, but then your butt's like getting flatter. And so what I've found is like then harnessing all that fat from like the lower abdomen from what I'm going to actually be removing from the tummy tuck, liposuctioning the waist, the mid back bra roll area, maybe the inner thighs. I harness all that fat and then I inject it into the booty after. So I think lower body lift BBL, that's a great one to combine breast, belly, also brachioplasty, so arms with the breasts. But I wouldn't do anything like where you're going to have all of your limbs incapacitated, like arm lift, thigh lift. It's like, like you're just like kind of in a cast.
You can't move, you can't do anything.
Yeah, so I think it's good to have like a surgeon who will be honest with you and let you know what's the best order of events and what's going to keep you safe.
Yeah, most definitely.
And sometimes patients want like belly and thighs. And that's just too much as well. That
really?
I've done it once, because a patient like begged me. She was like, I really just want to have one surgery and my thighs really bother me. My belly really bothers me. So I did a lower body lift and a thigh lift. And I regretted it. The patient regretted it. She ended up having a really nice outcome. But the recovery
was really hard.
And I don't know if you guys have seen that. Like,
I haven't seen
a lot
that
of like that combos between those two. It's not a good combination. So I'm not doing it again. It is way too hard to recover from. Plus, sorry to interrupt. Plus the forces that you're doing, you're like, pulling down with the belly, the lower body lift. And then you're like, and then pulling up and in with the thighs. So it's like opposing forces that don't work with physics. And it's just not good.
Physics was not on her side.
You were, but physics wasn't.
Exactly.
Yeah, because I have one lady who just came back from the DR and she wanted a thigh lift with a body lift up here, and her doctor told her no. So she's like, oh man, now I'm going to have to go back. And I'm like, it sounds like it would be terrible as far as recovery goes, because I don't understand how you would, do that much. You're already complaining about the thigh lift, but then to also have all of this lifted.
Yeah. Highly recommend splitting it up.
So let's talk about the body lift, because that seems to be like something new. That's not anything I don't feel like people have been doing for years. So what does that look like, that type of candidate? Is it just someone that has had like a lot of weight loss, or?
Yeah, so someone with just like a lot of extra skin. So in patients who just have localized area of lipodystrophy, as we call it, or like stubborn fat pockets, we can just do liposuction and maybe do some Morpheus 8 or radiofrequency microneedling to help like tighten the skin if they already have pretty good skin quality. But in someone who has had massive weight loss, if you can imagine like an elastic band being stretched, and then it's stretched to the point where it doesn't contract back like it used to. That's what you're dealing with the massive weight loss patient population, is like that skin gets stretched to the point where there's no return. Like in most patients who haven't had massive weight loss and maybe they lost 20, 30 pounds, their skin will accommodate. Their skin, once they lose the weight or once they get the liposuction, their skin will shrink wrap. But in massive weight loss patients, it usually doesn't do that because the skin is just the collagen and the elastin. It's already too stretched out. And so we just have to cut that skin out. So that is what a body lift entails. And it depends on what part of the body they have the extra skin. And that is very dependent on the individual patient, because some patients will have almost no extra skin on their back versus someone else will have a ton of skin, where their bra rolls are. So it just depends on the patient. And that's why it's really good to go to a board certified plastic surgeon who's also really good in body contouring, so they can like tell you what's going to be your best bet in terms of like skin removal.
And what's the recovery time for a body lift?
Yeah. So 2 weeks for desk work, 3 weeks to go into work. So I would give yourself 3 weeks.
Okay. Because it's really just skin removal.
Basically.
Basically.
But with the lower body lift, it's like the tummy tuck in combination with removing the skin from the lower back. And it's like, it's not like it's like the really lower back, because the upper back lift is kind of in the bra line area, but the lower body lift just goes all around the lower body, which is like basically an extension of your tummy tuck incision all the way to the back. But again, I try to hide that scar so that you can wear a bikini, you can wear cute lingerie, and it's all just like within like, a bikini strap or something like that.
Okay.
That's really nice.
That is great. And how did you end up getting into like doing like the body lifts? How did that become like a thing for you?
Yeah, great question. I think like I started getting several patients who had like I did their body lifts and they were just so thrilled that then they went on word of mouth. They go on these like Facebook groups and like it's so interesting because patients a lot of times tell me like, oh yeah, I found out from you from like you get such rave reviews on these like Facebook mom groups and all this other stuff, and I'm like, I have no clue, like I'm like clueless. I'm like,
it's a big community on Facebook.
Yeah, so it's an honor. Like one time I had 3 or 4 girlfriends from Florida. Like one came, because I get quite a few patients from like just the Southeast general area. And one found me, came to me, had surgery. And then like 2 or 3 of her girlfriends then came afterwards when she recovered. And that's like always like the biggest form of flattery.
Right.
Is like
that's how you know you're doing a good job.
Yeah.
When people recommend their friends and family to you and they actually follow through and come.
Yeah.
Oh yeah.
Yeah.
I'm doing my thing out here in the streets.
Well, you too. Like you guys also word of mouth, like I've had patients like just rave about you.
Oh, thank you. Thank you. We try to do what we can out here in these post-op streets.
Oh my gosh, but post-op recovery is important.
Yes, it is.
And it's important to have like a good team, good support system, great nurses.
Great doctors. Great doctors. Okay.
Team effort for sure.
Most definitely. So tell us about the consultation process.
Yeah. So the patients, they'll either like go online or they'll call our office. There's a $200 consult fee, but it goes towards your surgery. So it's basically like grouped into whatever your quote is going to be. And I do my consults on Tuesdays and Thursdays. Okay. And I like to be very involved in everything with my patients, from the pre-op process, to intra-op, post-op. So I see the patients, I do my consults, which are all an hour each. So, sometimes it might take a little while for patients to get like a consult with me. But then they can go on a list, and if we have any openings, then, we can have a patient come in earlier for their consult if something opens up. But it can be virtual or in office. And consult, like I said, takes about 1 hour. And then Alana, she's our office manager, and she's my right-hand woman. I tell her basically what I plan to do for the patient and how long it'll take me in the operating room. And then she crunches the numbers. That way I can stay like completely objective with what I recommend. Right. Because I'm just like, I don't deal with the numbers. I don't do anything. I'm just tell her, this is what I plan to do. This is how long it's going to take.
That's good.
And then she works out all the like details with the patient for the logistics and the payments and all that. And then I have another pre-op appointment so that's not the end. Like that's not like, we don't go to the operating room next. Like the next part is the pre-op appointment, which is another hour-long appointment before your surgery. And at that appointment, then I electronically prescribe my patients medications to whatever pharmacy they choose within Georgia. And then we go over everything in their preoperative folder, has their instructions and all that. And at that point, they can have a support person with them. And then we go into the lobby and discuss the post-op recovery. And then we take their official preoperative photos. And then I do the physical exam again, just to kind of like refresh my mind and the surgical plan. And then after the surgery, then I see them, my patients, for most operations, 1 week, 1 month, 3 months, 6 months, and 12 months. Okay. If it's like a face or neck lift or a blepharoplasty, like I might see them a little sooner. But for most like body contouring procedures, that's how often I follow up with my patients. And then if it's like breast augmentation with implants, those patients I also follow like annually, just to make sure their implants are doing well. And they don't have an extra, scar tissue or capsular contracture or any like problems with implants. Yes.
Let's talk about implants. Yes. I think that's something we haven't really talked about a whole lot on our podcast. Yeah. So a lot of people ask over the muscle, under the muscle, all these different type of implants. You got the gummy ones and, all these different things. So what all do you offer?
Yeah, that's a great question. So with the implants, I like to use smooth silicone gel implants. So textured implants have been associated with some types of breast implant associated like lymphomas and squamous cell cancers. So I just don't want to take the risk. So I would say most plastic surgeons in the United States only use smooth silicone gel implants and not textured. Okay. The textured implants are called anatomic implants, and those are the ones that can have like a teardrop shape. So those are the ones that actually, the smooth round ones, they're like basically, it's like round, even if it like were to kind of rotate within the implant cavity, like it stays put. Like the textured ones that have like the teardrop shape, if those like flip or something, then that can be
funny.
A hassle. Yeah, to like get it to like flip back, and sometimes you need to operate on that.
Oh wow.
So what? Oh, okay. So I keep seeing things about this implant illness. Have you ever seen? So what is that about? Can you tell us more? Because I'm not really familiar. I don't know anybody personally that's had breast illness, breast implant illness.
Yeah. So it's, like how when COVID happened, we all thought, like doctors and nurses and everyone, we all thought like we were doing well and we knew like a lot about the human body and all that. And then COVID just proved everything wrong. We just didn't know anything. We don't know what's going on here. Yeah, it's so true. And so I think the same kind of thing is with implants to an effect. Like some patients' bodies just don't really like accept the implant, or they just don't, their bodies are just like kind of rejecting it. Like, I don't want this foreign thing in my body. And usually breast implant associated like illness is extremely rare. I've only had one patient who has had it, and she had her implants taken out, and she was in Ohio actually. And then she felt better after her implants were taken out. But it's extraordinarily rare and you don't know who's going to get it.
Yeah.
So usually it's a diagnosis of exclusion, meaning you want to make sure you don't have some type of rheumatologic illness or an autoimmune condition. So usually if patients were to have, because the symptoms are so vague, like, like muscle aches or hair loss or fatigue. I mean, that can be like anything. And so usually if someone were to think that they might have breast implant associated illness, then I would refer them to a rheumatologist, have them worked up, make sure they don't have an autoimmune condition. And then if everything comes back negative, meaning that they're not found to have any other disorder or disease, then you would be able to, take the implant out.
So I did have one patient a couple weeks ago. Her surgery was it had to been a year ago. But anyway, for like a year, she continued to just have these fevers. And the doctors, they could never figure out where the fever was coming from. She was fatigued. And the implant literally had started coming through her skin. She thought it was like a bump, and then they thought it was a cyst at first. And so they sent her to another surgeon, and the surgeon was like going to remove the cyst. And then the surgeon was like, wait, do you have I think that's your implant hanging out. And she was like, what? So apparently that was like a plastic surgeon like next door. So I think she was like Kaiser. So, they have like all these different places, people inside the same place. So she went next door to a plastic surgeon, and he looked at it and he said, that is your implant. Wow. Trying to literally escape your body.
Yeah.
And she was like, oh my God. And sure enough, the doctor, he had to go in, remove it. And she had a lot of dead tissue and stuff in there, and he cleaned it out. But for a year, she just like kept spiking fevers over and over. And said they kept putting her on antibiotics just to kind of cover, but they didn't know what was coming from. She didn't.
It might have been infected too.
Yeah, but it literally tried to escape her body.
Oh my gosh, that's
isn't that crazy?
Yes, that's crazy.
Yeah, and so we don't know who's going to get it.
You just never know.
So that's why I spend so much time with my patients, like at the pre-op, like, at the consultation, at the pre-op appointment, just going over all these like potential risks. Like usually I tell them like the surgery's going to be great. We're going to treat you, just like family, but these are the risks associated with operation because everything can be just perfect in the operation and the patient can be completely healthy. And then, you might develop breast implant associated illness, like BII.
Randomly.
Like you just don't know.
You don't know. And so when you talk about BBLs, right? I know one thing a lot of girls talk about is that projection. Everybody wants projection.
I want it to be
big and round. And
I need that Ari booty.
Right. So what do you kind of like tell your patients? Do you just kind of go for like more of a natural look, or you kind of ask them what they're looking for?
Yeah. So with my patients, I always kind of try to get down to the bottom of what they're going for and the look they're going for. Like, it doesn't matter as much what my aesthetic is. Like, you're coming to me, you're paying like really, top dollar to get a certain look. And so as long as it's safe, like I want to give the patient what they want. And so that's why also for like breast surgery or booty surgery, I have them show me like a wish pic, because then that lets me know what look they're going for. Because I've had women tell me like, oh, I want really natural breasts. I just want like an implant, And then I see their wish pic and it's like, like Holly Madison or something. And then I'm like, that is not. So everyone has a different like concept when you're verbally talking about something. Like, I want to be perky and natural. And then you see a picture and you're like, oh, wow, that's not what I was expecting. So same thing with booties. I like to see a wish pic just to kind of see what they're going for. And it lets me talk to the patient about expectations.
Them being realistic.
Because some patients, no matter what I do, you're not going to have, a Kim Kardashian booty or, a Nicki Minaj booty. Like I cannot, there's no matter like how much fat I put in there, your body is not made like that. Your skin envelope like is not going to accept the fat in that way. And so in patients who want like a bigger butt, but they have really tight skin, like say they've said, oh, everyone in my family has flat butts. I've always had a flat butt, even when I gained weight. I know that they're probably going to need a couple rounds to get them to where they want to be, because it's kind of like a balloon. Like you can only fill the balloon so much at one time. And so when I put the fat in, there's a point where it is not going to expand anymore. And if I try to expand it further, you can get like a bubble or you can get like a weird contour abnormality. So you want to stop kind of while you're ahead, wait for the swelling, all that to go down. And then maybe like 3 to 6 months later, then we can do another round.
Okay.
But yeah, a photo really helps for me to kind of see what the patient's going for.
Has there been anyone you're just like, yeah, this is not, yeah, no.
So there are quite a few patients who and patients who come to me, I feel like overall, like I love my patients because they're very reasonable. They're very honest. They're very realistic. And I think the type of plastic surgeon you are, you kind of attract your type of people. Yeah. And so like, I like to consider myself pretty like even keel and honest and cool. And so I don't really attract crazies, you know? Like, I don't really attract. So I like to think of myself as like
you have all this
cool,
good energy around you.
Yeah. And so the patients who come who are like really unrealistic or whatever, like I just have an honest conversation with them. And I'm like, I don't think that I can deliver what you're looking for. And so I recommend that you go see some other plastic surgeons and get some second opinions. So.
That's good.
And I always tell my patients that, like when they come, I'm like, you need to feel this is not like open heart surgery. Like, like you need to feel very comfortable with your plastic surgeon because a lot of times for like the massive weight loss patient population and other patients, like this is like a lifelong kind of journey and partnership, you know? And so you want to be in it with someone that you feel very, like a plastic surgeon, you feel very comfortable with.
Yeah.
Most definitely.
And usually with those type of clients, they go to the same doctor over and over and over.
Once they find someone they like, they're like, you're sticking with her.
Oh yeah. No, I've had patients who have, I've done their body work, I've done their rhinoplasty, I've done their blepharoplasty, then I've done their facelift. So yeah, it's definitely a journey.
It's definitely a journey. And they want you on their journey. So that's important.
Exactly. And I feel like it's a real, like, I feel very honored when patients like choose me as their plastic surgeon. I feel very honored when like patients are like, I have seen multiple other plastic surgeons and I choose you. Like, it's just like, it's like, it makes me feel very special. And I'm just like, I don't take that lightly, like I want to give them the best result possible. And I also want them to feel very comfortable when they're with me in the consultation and in the operating room. So whenever they're going to sleep, I'm holding their hand, while the anesthesiologist is putting them to sleep.
So
like those little touches that just make them feel comfortable. So, yeah, I love my job.
Do you do anything awake?
I can tell.
Okay. We do quite a bit awake. So we do awake lipo.
Okay.
So we have Pronox, which is like the laughing gas. And then I also prescribe my patients like a Xanax. And we'll do awake lipo if it's a certain amount of areas. So 3 or less areas. So upper and lower abdomen and waist, or say like bra roll area and waist. I wouldn't do like arms, upper, lower abdomen, waist, back, inner thighs all at once. Like that, I'd want to put you to sleep for.
Yeah. Right. Yeah,
I think I'd want to.
There are a lot of fluid shifts too with that, so you want like the IV, hydration from the anesthesiologist and all that. But so we'll do some awake in office lipo. A lot of times we'll do the chin area as well. So we'll make a small incision underneath the chin, do some liposuction under there. Blepharoplasties, upper blepharoplasties, so upper eyelid lift surgeries. We do those awake. Very straightforward, easy. Because it's usually what you don't want the Kenny Rogers look of like long time ago where it's like hollowed out. So we don't, for upper blephs, usually don't remove very much fat, if at all, or muscle or anything. All you do is just skin only. So when we inject the local anesthetic and then we remove that skin, that's a very easy surgery to do in the office.
I mean,
how long does it take? About an hour or two?
Yep. Less than an hour.
Really?
About 45 minutes. Yep.
Are you kidding me?
No, it's great.
I don't know. I just couldn't imagine being away for that. I don't know.
Are they looking? I mean, what are their eyes
closed
doing?
Oh,
because they're awake, but what are the eyes doing?
I'm like, oh God.
So that's why I do not do lower blepharoplasties in the office, because for lower blephs, they can't really have their eyes closed because then their eyelashes are in the way. So then their like eyes are open, and then it's just like awkward and weird and uncomfortable for everyone. So I don't do lower blephs in the office, but upper blephs, they can have their eyes closed once I mark them. So I'll mark them in the sitting, like upright sitting position. And I take my marker, then I use a caliper and do all the measurements. Again, that's one that I do measurements for. From the lash line, I measure about 10 millimeters, or where your
You were
natural
really good
crease
in
is.
math, right? Growing up.
I liked math. Yeah, I liked calculus.
Geometry.
I liked math a lot.
You can tell I gotta get these measurements.
Yeah, so I'll do all the markings and everything, and then they'll lay down. I'll ask them what music. Like, I have the right to veto, like if there's a certain music I don't want to listen to that day or something. But I usually ask my patient, like, what would you like to listen to? And then we play music for them. They, get a little bit of the laughing gas. I inject the local anesthetic. We remove the skin and sew them up.
Wow. That's very interesting.
It's very.
I didn't know that was
So during the procedure, their eyes are closed. They're nice and comfortable. Yeah. It's just the very beginning when I have their eyes open and I'm doing the markings. But at that point, that doesn't hurt. I'm just like using a marker.
Yeah.
What else do you all do in the office?
Buccal fat pad removal. So like to, get that chiseled kind of like a hollowed area underneath. But I very rarely recommend that. Yeah. Yeah. Exactly. Like that contour. Cheek
most
look.
definitely.
Yeah. But I very rarely recommend that. So I don't want to hollow people out too much, because then that can age you.
Yeah.
So it's only for
most
someone
definitely.
who has a very round, youthful face. They want just a little bit of contour. And that, we make the incision inside the mouth. We numb you up, just like as if you were at the dentist's office. And then just remove a little fat. Buccal fat.
Because I've seen a surgeon say that once they do that, your skin can sag earlier.
Yes.
If they do too much.
Exactly. You want to be very, very conservative with the amount of fat that you remove. Let's see what else we do. We do scar revisions in the office. So inject some local anesthesia and then just redo a scar if a patient has like a keloid or something. Let's see. We also do. Oh, I did something interesting the other day in the office, which was a first. I did a brachioplasty, which is an arm lift. And so we just did one side, and then I'm going to do her other side this upcoming week. But the reason I only did one side at a time was I don't want to overdo or max out the amount of lidocaine that I can use, because you don't want them to get local anesthetic systemic toxicity last. And so so I just did one arm. Basically, I marked her. We injected the area and then tightened up her skin.
So what? She didn't want to be put to sleep?
Yes, and she was also trying to save a little bit of money, and so like when patients are put to sleep, there's the anesthesia fees, there's the facility fee and the surgery center. So our facility fee is much lower than because we have our own like sterile procedure room, or we have a 2-story office, and on the ground floor we have our sterile procedure room and we have our med spa, and then upstairs we have like our patient pre and post op rooms. And so if we do it in our office compared to the surgery center, it's just more affordable for the patient. So I don't usually like that. That actually went very well, and it was, pretty straightforward, but usually I like to have patients asleep for the brachioplasty. But she did great.
She did great.
Yeah.
That's amazing.
Everything went really well. Yeah.
That is.
It is safe. That's the thing. Like, you want to make sure it's safe. So that's why I was like, we can only do one arm. Like, I can't give you, I want to make sure that you're comfortable and you're fully numb. And so I don't want to be not giving you enough anesthesia, local anesthetic for one arm and then trying to do both. No, let's just bring you back to the other one next week.
Oh, cool.
That's interesting.
That is awesome. So the med spa, what all do y'all offer with the med spa?
So we do hydrofacials, we do radiofrequency microneedling, and then we do laser hair removal with the dialase. We have lymphatic massages, which are really important after surgery as well. And what else do we do in the med spa? Chemical peels.
Oh.
Yeah, so kind of like basically all the things.
I know a lot of people are doing like the whole fillers and the Botox now, and I'm just like,
I do that myself. So I do my own fillers and Botox. I guess I just like the control. I like to I just want to.
I was just working.
So I do my own filler and Botox.
Oh my God.
We do it all.
I love that.
We do it all.
So how did you get into doing that? Is that just something that's kind of fell into your lap because you're already at the surgery center, or just?
Yeah, I mean, basically you just get trained in it. Like that's like, the, I guess, quote unquote, easiest part of our training, versus like doing face and neck lifts and recons and cleft lips and palates. Like the filler and Botox is kind of, it's part of our training, but it's not like that difficult, but you want to go to someone who's skilled and trained in it. So I just was like, well, I'm a plastic surgeon. I can do it. I want to do it.
Yeah.
I'll do it. Put me in, coach.
And you have to be really good with that mapping. And it sounds like you are.
That sounds great. And you love drawing on people. And you got the eye. So I'm sure your patients look amazing.
It's funny though, because like I've never been like an artist. Like my husband, so he's a vascular surgeon, but he like draws and paints, and I'm just like, dude, like you should have been a plastic surgeon. Like you would be really good. And here I am trying to draw like Sonic the Hedgehog, and I'm just like having trouble. Like I just cannot draw on paper, but like on patients' bodies and faces and stuff, like that's where kind of like it comes to life. And I actually am an artist, but it's just so funny because you would expect all plastic surgeons to be good artists, but then on paper or sculpture or whatever. No, false. No, that's not the case. So, and that's also one of the reasons why. Well, I thought plastic surgery was just like so. Just superficial and fake. And I had all these notions, before. And that's why I wanted to be a general surgeon. That's why I wanted general surgery residency. I wanted to be a real surgeon, quote unquote. And when I saw plastic surgeons at the end of my first year in training, and I saw like all the awesome things that they do and the transformations that they make, that's when I was like, oh, this is like really cool. And plastic surgeons don't get enough credit for like what, I don't know, what we do. Like you see them, plastic surgeons like dancing on TikTok or other things. Like it is like, we're surgeons. Like
it's a real
this
job.
is real stuff. This is surgery. Like we are cutting on people. We are doing all these things. You have to know what you're doing. You don't want to go to some nut job out there who doesn't have the right training.
The basement doctors.
Right.
Exactly. It is surgery. It might not be, taking your gallbladder out or something, but I can do that too. But, but no, this is surgery. So you got to be careful who you go to.
Another thing too, a lot of girls that we're starting to see more in the post-op world is butt reductions. Have you been seeing a lot of that? Have you had any consultations? Anyone want to kind of reduce or reshape?
So not too much. I think because my patients, like I go for the natural look anyways. I've only had one patient ever want to be a little smaller. Her husband was like devastated. He was like, I love your butt and I don't want it to be smaller. But she's like, I just want it to be a little like smaller. So I've only had one patient ever of my own that I've gone in and reduced her butt size just by a couple hundred cc's on each side. But no, I haven't had too many consults for that. Maybe those patients go to their original plastic surgeon who maybe it's probably another niche. It's probably another niche field. That's
what I'm gonna say. I think it's a couple doctors that have been identified that's like starting to be like their niche now, like the BBL reduction. So yeah. So you can do some lipo in that area and then do some like radio frequency microneedling or some type of like skin tightening. That's what happened, The only thing, so a lot of my patients are African American. I would say like 2/3 of my patient population just have more melanin in their skin. So either African American or Latinas or Asian Americans. So my patients, I am really concerned with like scars and healing and all that because
darker people heal differently than like my white patients. And so with some of these like reductions, I know that sometimes surgeons will use like Renuvion or J-plasma stuff to tighten the skin. The only thing that patients have to be aware of is, especially in darker skin patients, you can get like burns that I don't know if you've seen that.
Oh, yes, most definitely.
Yeah.
And so that's why I don't use those type of like J-plasma and stuff in my practice, just because I don't want to risk giving you like a burn.
And another thing too that my doctor told me is he wouldn't use it on me because I have stretch marks. So he said your skin is even thinner. And it's going to thin it out more. And I'm just not going to do that on you.
Exactly. No, that's very true. Very true. Yeah.
So you feel like the lipo burns that people talk about, you think it more so comes from when people are using like that Rejuvenon or the J-plasma versus someone that's only getting lipo?
I think it's more common if you're using a heating device. Even the American Society of Plastic Surgeons, like they had sent out an advisory or a letter to the plastic surgeons and, in the email group saying, please be careful with these products, like in this equipment, because we've been seeing and hearing about a lot of people reporting burns. That's why I don't even want to mess with it. Like, no, I think that we'll do your lipo. I'll see how much your skin contracts. And I can tell a lot of times beforehand, like, stretch marks or massive weight loss, patients, their skin just might not contract like another patient would. So I might just tell them, it's not worth it to do that. Like we should just, instead of doing lipo, you should just get a tummy tuck or, a brachioplasty, an arm lift, and not waste your money on like just doing liposuction. So that's why, again, it's just, everything comes down to the plastic surgeon and if they're honest with you and, and also just skilled in what they do.
And also, too, just going to someone that really knows and understands the difference between the loose skin and, what you really need. Because sometimes some doctors are just like, you want this? Okay, let's go. So I think it's really good to make sure you find a doctor that's willing to be honest with you.
Oh, definitely. Yeah, so important. So important. And you don't want to waste your money either. You don't want it to be unsafe, but then also, like, you don't want to waste your money.
Right.
Like, that's why I, like, whenever I see my patients, I literally, like, think of them like, okay, this is my mom. Okay, this is my sister. Like, what am I going to recommend? What am I going to tell her? Or this is me. Like, okay, I've just had, my whatever, however many kids. And like, now this is me. What would I tell myself or what would I recommend to myself? So I always like put myself in their shoes and like what would give them the best bang for their buck? What would be the safest for them? And what would give them the best outcome?
I was having a conversation earlier today with a patient and we talked about dog ears. Now, do you feel like dog ears, or is that like a surgeon thing, or it's like something that someone does, if they done something incorrect during their healing process at home? Is there a way to prevent it? Like, how does that happen?
Yeah, so it's usually a surgeon thing. So if you're a patient and you have a dog ear, I would not beat yourself up over it or like feel like you did something incorrectly.
Right.
It's usually the surgeon just did not take the incision out far enough. So if you can picture having a shirt, like a blouse, and you're tucking it into your pants, and then the side, you're having like a little bit of your blouse kind of coming out of the pants. If you don't tuck in at the side there, your blouse, it's going to still be like poofy there.
Right.
So same thing with the tummy tuck. Like if you don't go far enough out, it's not going to be flat. So you have to kind of chase it, if you will, the extra skin to a point. And so usually you can see the dog ear on the table, like while the patient's asleep.
Really?
Yeah. And so sometimes, you have to chase that dog ear all the way around, and that's a lower body lift. So it's like, if the skin just keeps going and going and going, then I tell my patients, like, we're going to need to take this all the way around circumferential.
The one lady, she had a breast reduction and she had like a really bad dog ear. And she said the doctor told her because she had gained weight. And I was like, well.
So in the breast area, it's a little different because sometimes, so you have the demarcation of where the breast stops,
Right.
and where just like the subaxillary region or like the, the skin on the side starts. So the breast in like someone who has really large breasts or has had massive weight loss, sometimes those demarcated areas aren't as clear. And also they have extra skin there. So sometimes if you're just doing a breast reduction or a lift, then you might be left with some of that extra skin on the side. And the only way to take that out is to cut it out.
Right.
Or to go and take it into an upper back lift. So that's why sometimes I'll do a mastopexy or a breast lift with an upper back lift, because then again, I can chase that extra skin all the way around. So it's nice and tight.
And I'm sitting here thinking, do I really want a breast reduction?
Maybe I just need a little.
Most patients, you don't need that unless it's a massive weight loss situation.
Because
most patients do not have
I see
that.
a lot of ladies with that though sometimes. And now that you say something, it usually is a weight loss patient.
And then a lot of times you can also do just some liposuction in the area at the time of a breast lift or a reduction. And so again, depends on the skin quality and the patient's history and the physical exam. So sometimes I'll just do liposuction and that'll take care of it. But in terms of like, if there's a lot of extra skin, lipo's not going to do anything for that. Again, you're just going to be wasting your money.
Wow. So with breast reductions, do you all take health insurance?
We don't. And you know what the funny thing is Nurse Fonda, like I tried to get on insurance plans when I came to Atlanta and I applied because I thought that I wanted to do like 50% reconstructive surgery, 50%, like breast recon, lower extremity salvage, stuff like that. And then 50% cosmetic. And then when I applied for insurance, the insurance companies denied me. They were like, no, we're good. They're like Atlanta. So Atlanta, as you know, is saturated with plastic surgeons. We have a lot of plastic surgeons and most of them are great, but we have so many that the insurance plans are like, we don't need any more. Yeah. They're like, we don't need you. I'm like, wow. I didn't even know that was like a thing.
Well, you know what, nowadays, so my one friend, when she had her breast reduction done, she originally started out trying to go through her insurance, but her deductible was so high. She was like, why in the world would I waste all this time going to get all this extra work done, trying to convince my doctor that I need this breast reduction, then having to find an in-network doctor when I'm literally going to spend only about $2,000 more, and I can just find my own doctor, not have to be stressed out, and just go do it and be done with it. So that's what she did. She was like, it just wasn't even worth the hassle. Because her deductible was $5,000. So,
and sometimes I don't like the work they do when you go through the insurance.
Yeah,
I'm telling you, because I got approved and I was like, I'd just rather pay out of pocket.
I have a lot of patients like that. So, and the other thing is that insurance companies will often dictate like you have to remove 500 grams in order to have this covered. And so sometimes, say you remove like 400 grams, they might be like, we're not going to pay for it. You needed to remove this much breast tissue. And it's an arbitrary number, like 500 grams. Like that's just like so stupid. It just doesn't make any sense. So they don't give the doctors, like basically the surgeons, the free reign to be like, okay, because regardless, you're lifting the breast, you're removing breast tissue. Even if you're not removing 500 grams, usually the patient's symptoms are drastically improved or gone. Like, or like, they don't have symptoms anymore. But the insurance is like, no, you have to remove this amount or we're not going to cover it. So also, I don't like that. Like, that's like, don't tell me how much I have to. Like, I want to give my patient.
So you can't even ask your patient. Your patient's like, I want to go from an F to a C. You're like, well, your insurance said that I have to do X, Y, and Z. So this is what we're going with, or else I'm not going to get paid. So
I talked to my partner, Dr. Wright Jones, and when I joined the practice, and I was like, by the way, I was like denied from insurance, and then he was like, honestly, he's like, don't worry about it. He's like, I would not appeal it, because I could have appealed it and tried to get on it. But he's like, insurance is just such a pain and a hassle and a headache and all this. And so I didn't appeal it, and I'm really glad.
Just kept it moving.
Kept it moving. Exactly.
Yeah. And nowadays, I think most people are just prepared now to just, if they want some type of elective surgery done. I mean, there's so many different options. You have the Care Credit and the Alphion, and most people are saving up with their healthcare savings account card, their flex spending card. So most people I'd rather just not even be bothered with the insurance anyway. So
and that's why the patients who come to me, they're like, I really like your breast work. I've seen your before and afters, all that. I would rather just like pay out of pocket and know that I'm going to have a really good result versus like, you know, get insurance to cover it and maybe not have the result I'm looking for. But I tell them when they come to me and I see that they're going to have a substantial amount of breast tissue removed, like, and I can like picture in my mind, like, yeah, that's probably going to be about 500 grams or so. I tell them like, hey, by the way, insurance will probably cover this for you. You know, there are some great plastic surgeons in the area who take insurance, but I don't. So I let them know. And then that way I can sleep at night. You know? Like, it's like, I like to be honest with my patients, get good night's rest and, you know that I'm not like pulling the wool over, what is it? Pulling the
shade the covers,
sheep size,
wool over sheep's eyes.
Yeah,
I don't know, something like that.
Wool over sheep's. I don't know, something like that. Yeah.
So my mom is from former Czechoslovakia, and so she she has a really thick accent when she speaks in English, and it's like really funny because growing up, she would always like say these like American sayings or like, and then but just like not say it quite correctly. So she would be like, instead of like, you know, like, oh, he's like a wolf in sheep's clothing, she'd be like, oh, that's like a lion in sheep's clothing. You know, like it'd be like just a little off.
No, like it's the wool over the sheep eyes because they have the wool that you know, when it grows too big, it goes over their eyes.
Yeah.
You got it.
Yeah,
you got it, Nurse Ebony. You got it.
That's funny.
Oh my God. So another thing too that I wanted to talk about was implants, right? So when we talk about implants, how does someone know if they want to just do like a lift or a lift with an implant?
Yeah. So again, it just depends on the surgeon and what they recommend and like listening to the patient and seeing what their goals are. So if a patient comes to me, again, I'd like try to see a wish pick, like what look they're going for. But if they have their own breast tissue that's pretty substantial and they just want their nipple to be in better position and just have a better shape, then I tell them like, hey, you can get away with just a lift. But if they come in and they're just really deflated and they've breastfed 5 kids and they don't have any breast tissue left and it's all skin, I tell them I can lift your breasts, but they're going to be really small and they're not going to have a great shape unless we add an implant. And we can also do fat grafting, but the problem with fat grafting, it sounds great on paper, but in reality, it's not that great because in the beginning, you'll be like swollen in a good way. Like your breasts will look nice and like perky and full. But then once the swelling goes down and once a lot of that fat goes away, then you're just like left with just, you know, just decent breasts, but not like great. So fat grafting on paper sounds great for breasts, but in reality, it doesn't work the same as it does like for the booty or when we inject fat in the face. It just doesn't like work the same.
I think that's good to acknowledge because a lot of girls are definitely looking at like, oh, what about the fat grafting to my breast versus the implant? Because they're scared. You know, people are saying a lot of things about implants nowadays. And so people are like, you know, it seems like a safer thing to do. So
the other thing to keep in mind with fat grafting to the breasts is, you know, like breast cancer risk and all this other stuff. It doesn't increase your cancer risk, but what it can increase are like little oil cysts or fat necrosis. So it might increase the amount of times that you need a biopsy to make sure that nothing is cancerous. And that can be really taxing emotionally and physically, you know, and psychologically, like to feel a lump in your breast and know that it's from surgery, but at the same time, just feel a lump in your breast and be like, that's like.
I haven't even thought of that. I had one client, she went and she had a reduction and then she wanted back because it was flat, you know, and she had fat added, but then she had to go back because one side was way smaller than the other side.
And the fat might not have taken the same. And I don't know what it is. It's like really interesting because the fat transfer to the booty usually works really well. And fat transfer to the face, same thing. I don't know why it just doesn't work the same in the breasts. And all surgeons say that. Like if you ask, like 9 out of 10 plastic surgeons will be like, yeah, we don't usually recommend fat grafting to the breast because it just doesn't.
Sounds like a good idea, but.
Exactly, but it's not in reality. Not. So then if patients are like, you know, I want a little bit more fullness up top, then I usually recommend like adding an implant if they don't have enough of their own breast tissue or if they want just a little bit
I feel like whenever I wear like certain things, I don't have enough. I want it to look like that. You know?
But there are push-up bras that can do that.
No.
She wants what she wants.
I just want to like You know, like, oh,
get some cleavage.
I want some cleavage.
Baby.
It's like I don't have any.
Yeah. So in that case, yep, that's when I would recommend to a patient that they get a small implant. And sometimes you don't have to get a big implant.
Right.
You can just get, a small implant that just is like a little bit like wider and lower profile. And so it just like will give you some of that fullness up top, but it won't add a ton of projection. If you already have like nice breasts, then you don't necessarily need a ton of volume. You just need a little bit up top.
Another thing people worry about is nipple sensation.
Yeah. I just talked about that with somebody.
Yeah. And so most patients will get their nipple sensation will change around the time of surgery. Either their nipples will be more sensitive or less sensitive. But then after several months, it usually just evens out. And it's fine. But in the beginning, they could be really sensitive or they could be kind of numb. It's extremely rare for your nipple sensation to be completely lost after any type of breast surgery. Very rare.
I think back in the day, that was one of the things that people were complaining about was the loss of nipple sensation. So I think just because technology has gotten so much better and, we're doing things different nowadays, so able to keep that sensation.
Yeah, exactly. Yeah. And then also sometimes with breast lifts, back in the day, or even some surgeons now, they'll do a nipple graft where they literally remove the nipple areola and then they place it, basically back on the breast. And I never do that because, if you do that, you're guaranteed to not have nipple sensation. Guaranteed. Yeah. So what I would rather do if someone has really protuberant, sagging breasts, I will tell them, I'm going to do the lift. I'm going to keep your nipple on a pedicle, meaning on its own blood supply. And I'm going to lift the nipple to where it should be. And then I will see you, virtually or in office in 24 hours. And if that nipple looks dusky or like it's going to die, then I can do a nipple graft and, save the nipple. But I'm not going to start off the bat doing that because I'd rather just try. And so far, knock on wood, I haven't had to do a free nipple graft. All the nipples have survived when I lifted them, even if they were down to the belly button. Because again, in training, you're told if your sternal notch to nipple is over 40 centimeters, you need to do a free nipple graft.
You remember all of that?
Oh, standardized tests. So, you go through all this stuff in training and you get told these numbers, but in real life, you can take a little bit of risks and then just know that, hey, if something happens, then you might have to change the plan a little bit.
Okay. Well, you are doing an excellent job out here in the post-op world and the surgery world. I think you are doing an amazing job. The girls that I've cared for look great.
Thank you so much. I appreciate that.
No problem. So tell everyone where they can find you.
Yeah, sure. So my social media is my first and last name, MD. So at Sabine, Sabine Lovell, Lovell, MD. And I'm kind of on TikTok. And I'm not really, I just have an account just to have an account, but it's not really my thing. I think the younger generation, maybe, I don't know. I'm just not really big into TikTok, but you can see most of my work on Instagram. And then also our website is museplasticsurgery.com. So you can see a lot of before and afters there too.
Yes.
Awesome. Well, thank you so much for joining us today.
No
Great conversation.
Yes, so much fun.
Yes.
Thanks so much. And our office
awesome.
Is between Buckhead and Sandy Springs. So it's on Roswell Road.
Okay.
Perfect.
So yeah. So
you all are doing a grand opening or some type of event?
We did an event a couple days ago.
We missed it.
I will be sure to invite you to our next event. It was really cool. We had our own patients and we did artwork of them. We did a photo shoot and it was really artistic and stuff. It was really cool. So so I definitely will invite you to our next opening.
Yes, invite us to the next event so we can show up and be like, hey everyone.
Yes, and our events are fun. We have specialized drinks. We have DJs. We have raffles. So
cool.
It's a good time.
Awesome.
That sounds fun.
All right. Well, good
Thank
job.
you.
Well, so
great
good.
job today,
So good talking to you.
Right?
Thank you.
You
And thank you for
too.
taking such great care of my patients.
Oh, no problem, girl. Your patients are amazing.